Providing oxygen to your brain is good. Dementia is bad. There's reasonable information that the more orgasms you have, the more brain oxygenation you provide, the less brain dementia you're going to have.
So having more orgasms is protecting your brain.
SSRIs raise serotonin. So like depression, which leads to suicide, and we can stop suicide. So it's a fabulous drug, right? Mm-hmm. But its effect on the neuron and on the synapse and on neurotransmitters in about 1 to 3% of people are irreversibly changed. You know, another crazy problem for young people is the dysmorphia of wanting to have a testosterone value of 4 digits. They love looking at themselves in the mirror. They love competing. They do anabolic steroids. And as soon as they get off of them, their testicles shrivel beyond belief. They get scarring of their tissue. They get a severe hypogonadism.
It's 2026 and we're just learning about these phases of orgasm. Did you know that having more orgasms could actually protect your brain and reduce your risk of dementia? Well, today we're going to talk about orgasms and how millions of people around the world are suffering from side effects of medications they were prescribed sometimes even as young as teenagers. I'm Dr. Rena Malik, urologist and pelvic surgeon, and welcome back to the Rena Malik MD podcast, your trusted source for leveling up your health, sex life, and relationships with evidence-based tools. Today, our guest is Dr. Irwin Goldstein. He is a pioneer in the field of urology and a sexual medicine specialist who basically founded the field. He has authored over 350 research publications. He's been involved on countless journal editorial boards and received numerous lifetime achievement awards. I can't even begin to tell you the number of accomplishments this man has. He's authored over 350 publications. He's been involved on countless journal editorial boards and received numerous lifetime achievement awards from some of the most important organizations in sexual medicine. He is literally one of the giants in our field. Without him, there would be no Viagra. Female sexual dysfunction as a study would not even exist. And he's responsible for training some of the most prolific and impactful urologists of our generation. He is literally saving sex lives everywhere. In today's conversation, we talk about the surprising impacts of multiple common medications, which can permanently alter the way your brain neurons communicate and cause sometimes permanent sexual dysfunction. We talk about conditions like post-SSRI syndrome, post-finasteride syndrome, and hard flaccid. We cover why orgasms can be difficult and what you can do about them, and why we're seeing an alarming rise in erectile dysfunction in young men, and the serious dangers of jelqing. You don't want to miss this conversation. But before we get into the conversation, I briefly want to let you guys know my Erectile Mastery course has launched. It is 4 modules with multiple lectures covering everything you want to know about erectile dysfunction, including lifestyle changes, what to do about it, what happens if you're struggling with erections. Basically, everything I tell my patients one-on-one when I see them in practice is exactly what you get. So check it out and see if it's something you might be interested in. It's an honor to have you here.
Well, it's an honor to be here.
Because you are one of the giants in our field. And you have, without you, there would be no female sexual, no female sexual function fellowships. There would be maybe no Viagra. I mean,
my gosh, a few things,
like a few major things that you've lived through.
Yeah, but without you, we wouldn't have the word. So to do it's an equal share.
But thank you so much for taking time out to be here.
So, we happen to be around your corner.
I know, worked out. So let's talk about orgasms.
Oh, we love orgasms.
We love orgasms. So let's talk about what's happening in the body that leads us up to orgasm. I love the way you describe it when you teach us about it. So I think it's a wonderful thing to share.
So ISWISH, International Society for the Study of Women's Sexual Health, puts on a consensus development sort of subjects. Mm-hmm. And we realized we had studied things like low interest. We realized we had studied things of low arousal, but we haven't yet studied orgasm. Mm-hmm. So I'm one of the 3 co-chairs, and we have, I think, 19 people, world experts in all these sort of regions.
Yeah.
And we're just putting together. Hopefully it'll come out in 2026. It's really fascinating.
Amazing.
We just sent it to all the players, and we got back feedback. And now we're going to do one-on-one interviews for what's there. And
yeah, it's good to see what goes on behind the scenes, right? Because people see these guidelines come out, but there's a lot of work that goes behind it.
There's a process, yeah. And but what's come out of it is totally fascinating. So we've redefined orgasm. We redefined the newer pathology parts of orgasm. We're consensing newer development strategies and treatment. And that's fascinating. So I hope, what I shared today hasn't been consensed, but I think it will be.
Yeah, that's okay. I'm sure we can fact check you at the end of it.
Oh,
when it comes
for sure.
out. But yeah, tell us what we know and what we still need to know.
So it turns out that there are multiple different definitions of orgasm. Different societies have put together explanations, but they're not clinically relevant. That's we're physicians trying to help people, and we have a lot of things that focus on the physiology, the muscle contractions, the sensations, that stuff, but it doesn't get you to sort of help the patient.
Right.
So we realized that orgasm is a sensory motor experience, especially orgasm during or sexual orgasm, because there's actually non-sexual orgasm. Like a sneeze is virtually an orgasm. A yawn is an orgasm.
Yeah.
They're all reflexes that make you feel good, really.
Yeah.
They provide you pleasure. I mean, a good yawn is actually very refreshing.
It can be, yeah.
Swallowing, you could argue, is one of them. But so the sexual orgasms, we could divide into phases, and we've never had that concept. So there's the build, the sort of climb the mountain. There's this very incredible arousal process. And why I say it's incredible is because there is no physiology equal to what's going on. So just as an example, classically, let's say you go to the bathroom, okay? So that's parasympathetic. You're activating, emptying your bladder, emptying your bowel. But you turn off the sympathetic when you do that.
Yeah.
Or let's say you're in Ukraine shooting Russians, or Russians shooting Ukrainians, depending, then you're sympathetically driven, and you're not going to have bowel movements and not going to have urination. So they're usually sort of opposites.
Right.
This is one of the physiologies where during orgasm, your heart is beating, your blood pressure is up, your respiration rates are high, so that's all sympathetic, but you're lubricating from your vagina, your pupils are dilated. There's a million other things going on that are parasympathetic.
Right.
So you have, for really one of the first times in physiologic history, the sort of duality of sympathetic and parasympathetic. And one of the most fascinating parts of here, take your pen. No, you keep it.
Okay.
And take your finger and put the sharp end into your pulp. Yeah. And it hurts, right?
Yeah.
You could take that while you're having sex with your perfect partner or by yourself, and you could jam it into your finger and you won't feel it.
Yeah.
So there is this amazing excitation, but to get to another level of excitation, you have to provide inhibition.
Yeah.
And it's inhibition of pain, really. But then you have to excite more, and then you inhibit more, and you excite more, and you inhibit more. And this duality of excitation and inhibition is completely opposite of what normally happens. When you excite something, you turn off inhibition. Like desire, the paradigm is sort of like a seesaw. You excite, but you have to turn off inhibition. But not in orgasm. It's completely different.
So interesting.
And you have not only, so if you did an fMRI during someone in that phase, the pre-orgasmic phase, so there's sympathetic, there's parasympathetic, but there's oxytonergic, there's serotonergic, which is inhibition. There's you activation of the adrenal gland. You're now producing hormones. So you got all of this stuff going on. I mean, if you do fMRI data, there's 120 brain regions called Brodmann areas. And you basically activate every one of them. And there's nothing like that. There's no, like we're talking. So our brain speech region is activated.
Right.
But a lot of other things aren't doing anything.
Yeah.
Whereas in orgasm, pretty much the entire brain is activating. So let's get into a real important take-home message.
Yeah.
Okay. Providing oxygen to your brain is good.
Yeah.
Okay. Dementia is bad.
Right.
There's reasonable information that the more orgasms you have, the more brain oxygenation you provide, the less brain dementia you're going to have. Just to tell you.
So having more orgasms is protecting your brain.
Yeah,
it's protecting your brain.
We believe that to be the case.
That's amazing.
That's a separate concept. All right. So there's a pre-orgasm phase which is like magnificent physiology that doesn't exist. The entire brain is going sympathetic, parasympathetic, oxytocinergic, serotonergic, dopaminergic, noradrenergic, hormonal. I mean, all these things are going on, and they're all sort of organizing to get to a point of excitation that you can't achieve in any other case. There's no way to get more excitation than during orgasm, because for men, you have to activate ejaculation. So that requires an amazing amount of brain information. Women have ejaculation, but they don't have to get so high to have orgasms. Women get more orgasms, like 2 or 3 at a time.
Yeah.
As they approach. But let's just stay with the concept that there's the pre-orgasm phase.
Yes.
Then there's an orgasm phase, which is basically you have this intense arousal, and then you have muscle that contracts but then relaxes. It's that contraction relaxation of muscles that's really pleasurable. Satiety is built into this process. And then you have to return to the real world again. You have this refractory period to get a new one, but you have to resolve all of this.
Yeah.
So you go from a very high adrenergic, dopaminergic, and adrenergic, to a very high serotonin state, which is the inhibition.
Yeah.
That's the satiety thing. But you got to get out of that phase, because there are a group of people who can't get out of that phase.
Yeah.
And they have this post-orgasm illness syndrome. Anyways, by dividing orgasm into phases, finally, for the first time, we can now define conditions within each phase that, if you listen carefully to the patient, will tell you what's wrong with them, which is really cool. That's never happened before. And then deciding on how to manage based on the characterization of their problem has never happened before, because it was just FOD, female orgasm disorder, and it was just this mush of conditions. But now we're separating and dividing the conditions, which is kind of cool.
That is cool. And it seems like also for men, right? It's the same.
It's basically the same.
There's like, I think they're trying to come up with a new nomenclature for male ejaculatory disorders too, but I don't know that there's a real clarity on ejaculatory disorders versus orgasm disorders in men.
Because they're separate and independent.
Right.
Like, especially after radical prostatectomy, you can still have orgasm, but you can't really ejaculate fluid because there's no fluid. But they're separate. You can have orgasm without ejaculation, ejaculation without orgasm. So what happens is the pre-orgasmic phase, we've recognized 4 conditions. So they're kind of cool. One of them is called excitation insufficiency.
Okay.
These are people who start the climb and they get somewhere in the climb, 50%, 70%, but they can't make it.
Yeah.
They don't get high enough. It's probably the most common form of orgasmic dysfunction is excitation insufficiency. As stated, it's missing the excitation chemical component in the brain. So we have a slug of therapies to help them. Then we have inhibition
Before we
insufficiency.
move on from that one, is that a lack of arousal contributing to that excitation inhibition?
Whatever. There's partner issues. There's hormonal issues. So there's multiple reasons for excitation insufficiency. But at the end of the day, looking through all the therapeutic interventions, we can give dopamine. We can give, for people who can't focus, we can give Adderall, for example. So it's kind of an amphetamine, noradrenaline activating drug. We can block serotonin with like Buspar or flibanserin. We can give bupropion, which is the dopamine agonist and norepinephrine receptor inhibitor. I mean, there's lots of stuff we can do. So that's for excitation insufficiency. Then we have because it's so common, right? It is.
If someone is struggling with this, how do they, obviously there's not a lot of doctors prescribing
you got to find an orgasm dude.
Yeah, so going on the Ishwish website is a great place to start to look for a doctor. But also, there's all these multitude of things. None of them, they're all off-label, right? There's no
single drug, and there will never be an FDA-approved drug to help your orgasm. It's not part of the FDA's thing.
Right. So obviously dealing with the psychological factors and the arousal insufficiency is separate. If they want to try a medication, what have you had the most success with in your experience?
This is a great question. Okay, so I would ask questions like, is your excitation insufficiency in part related because you can't focus? Like in the middle of sex, you're thinking of the Super Bowl, or you're thinking of paying the bills or the laundry or buying stuff for the kids that need for their Monday morning work or something. So with that, we use Adderall. It's one of my favoriteest drugs. It's off label, obviously.
Yeah.
But you get amazing focus on this. And you just have to take it before sex. You don't like live on it.
Right.
Like an ADHD or ADD person would.
Mm-hmm.
We use low dose. We use 5 milligrams, 2.5 milligrams if you can get away with it. And you only use it when you're having sex. So it's not like we're the psychology or psychiatry people working with ADHD. We also do dopamine. So there's bremelanotide, the subcutaneous injection, fabulous drug for this. Oh my God. Of all the agents on earth that have done double-blind, placebo-controlled, multi-institutional studies on HSDD, but since they collected the FSFI, which has other domains, we have data on orgasm. And just for the people listening,
that's a validated questionnaire that we use in research to look at all these various domains of female sexual function.
Female sexual function index.
Correct.
I shouldn't have used the acronym, sorry. Okay. But anyways, the FSFI has shown the intended outcome, which was to study the low interest state, HSDD, hypoactive sexual desire disorder. But at the same time, we got data on orgasm. So this is the first drug to have thousands of people in a placebo-controlled way. So we just finished the publication. It's accepted and about to be printed. So I'm not giving away the secrets here.
Yeah.
But it's one of those few products where, since you use it only at the time of sex, the placebo response doesn't march upwards. Like Viagra and Cialis, those drugs constantly had higher and higher. The more you involved yourself in the research trial, the more placebo. This was a flat placebo and a rising treatment. It's really an exciting outcome curve. So we have the most data with, it's called Vyleesi, but it's called subcutaneous bremelanotide. It's in an EpiPen thing. But we have Parkinson's drugs. Parkinson's disease is a low dopamine state. So we have, ropinirole, we have cabergoline, we have a myriad of things, L-Dopa, that are useful to raise dopamine. Then we have like bupropion, also raising dopamine. We have the opposite, Buspar, serotonin antagonists. And then we have like oxytocin. So instead of going to labor and delivery and get a Pitocin drip, we put in a lozenge and you suck on it just before sex. So it's a Pitocin lozenge. Or oxytocin lozenge. We have testosterone, which is commonly a reason for excitation insufficiency, so we would measure that and supply it. We have arousal gels, this new topical sildenafil. I don't know if you're aware of that. It's called Dare to Play.
I know there's some new papers about it,
so they'll have that at Ipswich. And then there is actually in Los Angeles, there's a product called Vela, Vella, which is liposomal cannabidiol. It's really cool.
Yeah.
It sort of releases the cannabidiol vasodilator over time because of its liposomal delivery. And on and on. I mean, I don't remember the whole list as I'm sitting here. But
I guess my question was just which ones do you find to be most effective? So in, that big list.
Yeah, so it's a combination. I'm sort of the Campbell soup dude. I don't like doing one at a time. I don't like failure.
Yeah.
I like success. So, and I think synergy is important in this thing. So we would do the amphetamine, we would do the dopamine, we would use the bupropion. So we'd use 5 or 6 things and just get them across the finish line to have an orgasm. And then we can pull one at a time and see what is it really that's active in this individual. And if there's side effects, we would hold back. But it's a lot of communication. It's a lot of time and energy. Our model is 3-hour visits, so it's not like people are coming in for a 10-minute visit. You got to figure this stuff out.
Yeah.
All right, moving on. There's excitation insufficiency, the most common. But there's this really cool thing called inhibition insufficiency. So remember we talked about you can put the pen against your finger and it hurts, but as you arouse, that exact same thing wouldn't hurt.
Yeah.
There are people who can't inhibit. For reasons unclear, they can't inhibit. We don't understand that one. But we do have inhibitors to help them. So that's really cool. So there's a drug for men who have premature ejaculation. Sadly, it's not available in the US, but it's available in the entire world. Prilogy is the name, and it's duloxetine, and it's 30 and 60 milligrams. And it's all over Europe and Canada, and Mexico, but I don't know what happened with us.
Yeah.
Another FDA thing. So duloxetine is an inhibitor. It's an SSRI, but only lasts for a short period of time versus the 24-hour version of SSRI. So duloxetine is very helpful for inhibition and insufficiency. They present like they're climbing the mountain. They don't get very far, but they can't go further because it hurts them too much.
Yeah. So they feel like they've had like sort of an after
They
effect.
try hard. It's too sensitive and I don't want to do it anymore, is what they say.
Yeah.
So they're not excitation insufficiency, they're inhibition insufficiency. It's not that common, but it's not that uncommon. We see a reasonable amount of this.
Yeah.
So we would provide tramadol for these people. Basically, it's the same treatment for men who have premature ejaculation, quite honestly. It's an opioid, and it's an SSRI, and we would just use Tylenol and ibuprofen, anything to sort of get rid of pain.
Got it.
So, and they would just take that before sex. And the two other parts of the pre-orgasm phase pathology, which is excitation and inhibition insufficiency, is delayed orgasm. Boy, is that a common problem. You try. It takes 30 minutes. It takes 45 minutes. And if you finally get there, it's a pretty good orgasm, but it just takes forever.
Yeah.
So other than drugs, which are, SSRI use or alpha blockers or medication's common problem. We're finding lumbosacral disc disease is really important in this condition. Basically, you have a disc. It's pushing out on the dura. It's in the cauda somewhere, like L4, L5, L3, L4, something. And it somehow picks on a afferent sensation genital nerve. So it's either pelvic pudendal, typically, and it interferes with the need for all this amazing sensory information going to the brain to start this reflex. So we've done spine surgeries on the endoscopic spine surgery with these patients. But we what we do is we do neurogenital testing. We have these weird tests that we do. It's perceptions of vibration, hot and cold from the genitals. We also do a bulbar cavernosus reflex, and we do sensory testing of the sciatic nerve. Anyways, we do that stuff. And then we get an MRI. Our spine surgeon, Dr. Chol Kim, God bless him.
He's been on the podcast before.
Oh, he has.
Yeah.
He's so good.
Yeah.
He does his own stuff too, I think. Yeah. He'll read the MRI. But then we'll send the patient for a steroid injection at the level of their lumbosacral disc region. So that lessens the inflammation. Theoretically, that allows more sensation, and they have better orgasms.
Yeah.
How cool is that?
That's pretty cool.
And then if needed, he could then operate.
And you're seeing this in men too.
As you age, the prevalence of lumbosacral disc disease is bizarrely common.
Right.
So yeah, it's what delayed orgasm ends up being from our point of view.
Right.
Independent of partners and independent of drugs and independent of hormones. And then the fourth one is women have and men have these premature ejaculations, little blippy things. They get an orgasm with minimal stimulation.
Yeah.
And they go back to where they are, and they try again, and bloop, So it's kind of a we call that excitation insufficiency along with inhibition insufficiency. We think we don't understand that one, but
so
it's
they're
clearly
like
a
less
reason.
Intense and premature.
Yeah, and they're muted, less intense, muted, and premature.
Okay.
So those are the four things we believe we can at least say. I'm sure there's 20 more, and we haven't figured them out yet.
Yeah.
And then the ones that occur during orgasm, that's the most problematic. That's called anhedonia, anhedonic orgasm. They have the orgasm. It's just like drinking water. I mean, the pleasure doesn't happen. And that's a big problem. SSRI, we have this condition, PSSD, post-SSRI sexual dysfunction. Anhedonia is really common.
Yeah.
We believe it's wherever the reflex is in the brain, and Barry Komisar could tell you more exactly where
he
that
was
thing
also on
is.
the podcast before.
He's great. Barry's
He's great.
amazing.
Yeah.
But sending ascending pathways from sort of lower in the brain to cortical is somehow messed up in these patients. And it's really hard to figure it out. And I think what's going to end up being is ketamine, the hallucinogens, that type of stuff is going to be where we're going to go with anhedonia. But
Interesting.
lack of pleasure and orgasm is awful. It's just
It
like
is
a
really
nightmare.
awful. Yeah.
And it often coincides with anhedonia of other things. Like they used to enjoy going for Greek food or Chinese food or something, get all excited by it, or go to roller coaster and get all excited. But they don't have that anymore. So there's
I wonder if, we know that the GLP-1s, their use is becoming very, very common. And I wonder if, it affects desire for many things, right? Food for some people who are alcoholics.
Yeah, you may be inducing orgasmic dysfunction.
I wonder, right? Are we
pretty sure
induce...
we've seen this already.
Yeah.
Yeah.
And so do you think that we're going to see more and more of this?
Yeah, I think so.
Yeah.
Yeah.
Because I think people are, there's so many benefits to the medication, obviously, but also this one is very under discussed.
Drugs causing anhedonia is commonplace, like we see it with finasteride. We see it with the SSRI post-patient use.
Yeah.
And then the final orgasm, so we have 6 named orgasm disorders, is post-orgasm illness syndrome. That's just an awful condition.
It is.
It's like the weirdest concept that you have this amazing orgasm, you get the satiety, you get the amazing pleasure, and then you're stuck in that state for 7 to 10 days. You have brain fog, lethargy, you can't concentrate, you can't think. Attorneys can't be attorneys. Sports people can't play their sports. This is their income, their lives. They have an orgasm and they're done for 6 to 10 days. So we can't get them out. So we don't understand. It's called POIS, post-orgasm illness syndrome. We're finding that IgE blockers, Xolair, Xolar, is this cool new way to deal with this. It's a mast cell thing.
Interesting.
But other than that, excitation, like giving them dopamine, because they're stuck in a high serotonin state and their dopamine, adrenaline, and oxytocin are zero. So we give them lozenges, we give them Adderall, we give them stuff to excite, to get out of this stupid serotonin state.
Yeah.
But there's some relationship to allergies, to mast cells that is kind of fascinating. The last guy we had with POIS had about 11 mast cell conditions.
Wow.
He has TMJ, he has IBS, he has asthma, he has, all of these sort of histamine things. And I don't know. This is a fascinating field. It's kind of like, now that we're uncovering a rational clinical strategy, theoretically it'll just take off and people will just say, oh my God, I remember seeing this patient, but I used that therapy. Let's sort of publish that way.
Well, I think post-orgasmic illness syndrome, it's ideally some sort of abnormality in the hormones after, right? In that inability to raise, as you mentioned, dopamine. It's interesting because, people talk about post-nut clarity. And I think that's like the normal, what we would expect is that because you're no longer in that like focused state of being so hyper-focused on getting sex and getting to the orgasm, that now you're able to focus on other things. But this is like the complete 180 of that.
Yeah. And you're stuck in that.
And you're stuck.
And even just nocturnal emission gets you into that.
Really?
So you're,
but that's like not even controllable.
Well, that's the whole point. These people are kind of screwed for a while.
Wow.
We really have to help them. But we have to help orgasm disorders. And
Absolutely.
it's very under-discussed, understudied. It's one of the very common sexual dysfunctions, but we focus on erectile dysfunction, Peyronie's disease, things that we at least can understand and treat. But orgasm is sort of like pushed aside as, oh, okay.
Well, I
you
also
have that too, sorry.
It's 2026 and we're just learning about these phases of
Isn't
orgasm.
That weird?
Right?
And it's all because of freaking Ipswich. If it wasn't for Ipswich, I don't know where we would be.
Right, but it's thank God, we have people like wanting to do this research. But if we're not doing research, if we're not like making these things a priority and we're not funding them and we're not taking sex seriously, like it's a problem, right?
Yeah.
Because people are suffering in silence.
Yeah.
Yeah, and there's not enough people treating these patients.
Welcome to America.
Yeah.
Sexual medicine.
Well, the world. Forget America.
That's a good
It's in
point.
the world. Well, I do want to talk about the medications that you said cause sexual dysfunction. So SSRIs, which are antidepressants, are
Right.
given widely,
Like
right?
water.
So how many
And
people?
to people who are minors.
Yes.
This is a nightmare.
Right.
These are people who, say it's 1 to 3% of all users will have this PSSD thing, which is a disaster. SSRIs raise serotonin. So, like depression, which leads to suicide, and we can stop suicide. So, it's a fabulous drug, right?
Mm-hmm.
But its effect on the neuron and on the synapse and on neurotransmitters in about 1 to 3% of people are irreversibly changed.
Why is it irreversible?
Well, we're writing the paper on this right now. We're deep into it. And you just have to study the animal studies that they do. They provide it and they find neuronal synapse and neurotransmitter changes that you don't ever get back. So there's something about the drug in genetically susceptible people that irreversibly changes their function. So that's a problem because we have tons of people who have taken this drug because they were unhappy changing schools and the parents gave them an SSRI so they would have less stress, okay? But without the knowledge that for the rest of their lives they would have no pleasure during orgasm. Give me a break.
Right.
Then you have to put the risks and the benefits together.
Well, yes, I think if someone's severely depressed and suicidal, that's you got to weigh the risks and the benefits, right? I tell my patients all the time, look, you have to weigh the risks and the benefits.
But stressful at school,
Yeah, that's
no
not-
suicidality.
I think we just need to be very, very thoughtful.
Or broke up with someone who's 14 years old, they
Yeah,
had their first love. I don't know. Because I see the people who said, I did not make this decision and I'm never going to have a sex life again. Wow. Woe is me. I mean, we see that over and over again.
And have you seen patients where they've just taken it for a short period of time and it's like, how long does it take for this neuronal adaptation?
So this is the weird part of PSSD.
Yeah.
It could take 3 years for this to happen, and it could take a month or a few weeks on this drug.
Yeah.
So who knows?
Right.
It has
Because
this
I've definitely
wide
seen
spectrum.
patients where they've been fine for years and then 3 years later they've started noticing that their whole sexual milieu has changed.
Yeah, and it's not like when we studied ED. We had patients who had ED. They had normal libido, normal orgasm, normal sensation, normal pleasure during orgasm. It was an ED sole sexual dysfunction. Boy, oh boy, PSSD is this bizarre multi-dimensional thing. No libido, poor sensation, anhedonia, erectile dysfunction. I don't know, whatever you can think of, it's not working. It's awful. It's so broad. So it's so individual how people present.
But some people get better, right?
So what I tell patients, because we see a lot of PSSD now, as our paper is coming out, it's like this paper, it's kind of like this thing that has been on for like 6 years. We've been developing this thing, but whatever. Each person has a unique presentation of PSSD. It's not like a cookie cutter, all PSSD people are the same. They are not. They're way, some people have no ED, and some people, their prime thing is ED. Some people, they can't feel their genitals. But it's not that they can't feel it, because if you touch it, they can feel it. But they don't get this, you touch your genitals, and it's supposed to be a pleasurable thing. It's supposed to be different than touching your arm. It's like touching their arm.
Right.
And it's not like this special thing. And on. It just keeps going. But we'll address each issue. So I'm not going to cure people with PSSD. They're not going to be back like they once were, if they ever had, which is like the minor people have never had, which is very frustrating.
Yeah. But
like people who are 25 and 30 who make the decision to go on, but they've had sex, they're not going to get back to the way they were, but they're going to be way more functional. We're so good with erections. We can really help people.
Yeah.
I mean, they may have to take a pill or a shot or something, or a subcutaneous injection, something, but we can get them functional that way. As we talked about orgasm issues, we can do that. We can help their libido because
Right.
you know
But
strategies.
you think that they're on their own, like with time, things won't improve?
Well, that's why they're presenting, because
Yeah.
things on their time are not improving.
Yeah.
It could be that there's a subpopulation of people who do improve, but we're not going to see them. So our
Right.
bias is we're getting the other population, the no improved version. Yeah, so beyond SSRIs, there's these 5-alpha reductase inhibitors. Boy, are they bad.
Yeah. Finasteride being the most common.
Finasteride being the most common, dutasteride being, and then you have the Accutane group, and then you have the minoxidil group. They're kind of all the same. They influence. The way it's proposed to the physician by the pharmaceutical groups are that this 5-alpha reductase is designed to impact negatively on the synthesis of dihydrotestosterone, period. Like nothing else is bothered. But there's like 10 biochemical reactions that depend on the activity of 5-alpha reductase, including stuff in the brain, for which we get back to the PSSD thing. There's a kind of an interesting similarity between what we call PFS, post-finasteride syndrome, and PSSD, post-SSRI sexual dysfunction, because of the influence negatively of SSRIs on the brain and 5-alpha reductases on the brain. There's a lot of biochemical reactions that would otherwise be used that can't be used because of 5-alpha reductase. And then we get into the reality that dihydrotestosterone is really an important hormone for the corporal, the penis smooth muscle cell. Without it, apoptosis or cell death happens, which turns into scarring, which turns into erectile dysfunction. That becomes permanent, or we can't really change the collagenization of the erectile tissue. That leads to this thing called venous leakage, and it's very frustrating. And these are people who are 16, 18. They look at themselves, their father's bald, their uncle's bald. They don't want to be bald. And they just go to the internet because you don't need to see a doctor for 5-alpha reductase inhibitors. They're not given any information on side effects or just briefly.
Yeah.
And they end up with this PFS thing.
Is that also permanent in your
I
experience?
believe it to be the exact same kind of concept.
Irreversible neuronal changes?
Well, let's just say that in many cases, their DHT remains low despite them being off the drug. So they have changes to the enzyme that may be irreversible, yes. So the thing is, like Viagra's an enzyme inhibitor, but it's a reversible one. Okay,
Yeah.
The 5-alpha reductase inhibitors are irreversible enzyme inhibitors. They cause suicidal changes to the enzyme.
Gosh.
Yeah.
So there's a lot of, I'm sure physicians listening to this, they're going to say, this is all false.
It's all false. Yeah,
Yeah.
Well, that's fine. I have no problem with them saying that. It's
what
just
do you
that
say to
they
them?
don't take care of these people.
Right.
And they may be invested in the value of the drug. For example, psychiatrists see the suicide.
Yeah.
I see the side effects. I see the sexual dysfunction. So my perspective is bad drug. Their perspective is good drug.
Yeah.
And then there's these hair people, people want hair. But they're saying how fabulous the drug is. And I'm saying, whoa, I'm seeing all the sexual side effects.
Right.
So I know it's just on the reality is the drugs cause these things.
And there's just no way for us to predict who's going to be
that's
the
nightmare.
problem, right?
Yeah.
Because it's a small subset of people, like less than 1% probably.
It's just that millions of people are on these products.
Right. It's given out like candy, a lot of these medications.
So if 50 million people are on these products, and 1% are having, that's a lot of people.
Yeah. It really is. That fibrosis thing is really crazy to me.
Know.
That's really scary.
Yeah. So we have a brand new ultrasound strategy. So there's urologists perform intracavernous injections, and then you get an erection, and then you do what's called a Doppler ultrasound. So it looks at the blood flow. But ultrasound that's Doppler, that's blood flow related, is a sort of a nuance. It's sort of a new thing.
Yeah.
The old ultrasound was grayscale, black, white, gray. You looked at a baby. You didn't look at the blood flow to the baby.
Yeah.
You looked at the facial features. You looked at the shape of the head, the arms, the legs. That's grayscale. So for reasons unclear to me, grayscale has been ignored by the urologic community studying this stuff. So we purchased a device that is a very high frequency. It's 15.4 megahertz. So it has amazing resolution with the probe touching the penis. Like when you examine a baby, you put the probe on the pregnant abdomen, and you're like a foot from the intended target.
Yeah.
So you don't need fancy equipment for that.
Right.
But when you want to get high resolution with 1 millimeter from the contact point of the probe to the erect penis, you need a fancy piece of equipment. And not everybody has that.
Yeah.
So we
Probably
have
no one. Probably.
we have the ability. We bought this $150,000 thing that allows us to get high resolution grayscale of the erect penis. So if you can get people in a rigid, sustained erection with intracavernosal agents, and you do grayscale with the device, if it's all gray, perfect. That's where blood goes everywhere. That's erectile tissue. If you take a person with 5 days of priapism and he's got kind of a dead penis, and you ultrasound that, you see basically black.
Yeah.
Blood
And
can't
just for
go.
clarity, a priapism is an erection that doesn't go away. When you've had it for 5 days, it means that
That's a
there's no
bad
more
thing.
blood flow going in or out, and all the tissue is probably fibrosed and scarred.
And if you're listening and you have it for more than 4 hours, get your body to an emergency room.
Yes, please. It's not fun. Go to the ER immediately.
Okay, having said that, in the state of priapism for multiple days, which is just an awful state, the tissue is basically dead.
Yeah.
So it's all basically scar tissue at this point. So no blood goes to those regions. So on grayscale, you'll see dark, like black.
Yeah.
Okay, so we have now a discrimination between healthy tissue, gray, and black tissue, which is sort of non-healthy tissue.
Or dead. Yeah.
Okay, so we have these thing called the erection hardness scale. I spent like multiple years
Yes,
on this
you
crazy
did.
thing.
Yes, you did.
You push down on a series of rods. One rod, when you push down, does not buckle, and we call that 4 out of 4 erection hardness scale, and that's like the normal physiologic boner version erection.
Yeah.
And then 3 out of 4, you press down on it. It buckles a little bit, but it's still able to have penetration. You press down on the 2, there's even more buckling, and you can't really proceed. But it's close to being good, just not good enough.
Yeah.
And then 1 out of 4 is this nightmare, like you press down and it has no rigidity.
Like
at
a
all.
noodle.
Like a noodle. Okay,
Yeah.
so there you go. So what we've now done is divide the gray scale by the erection hardness scale. So the 4 to 4 erection is all gray. The complete horrible thing is pretty much all black.
Yeah.
And then there's gradations of gray and black on the tweeners, we call them. So grade 3 out of 4 is mostly gray, but a little bit of black. 2 out of 4 is a little more
Yeah.
black. So we now are doing ultrasound on our PFS patients and our PSSD patients.
Yeah. And what do you
So
see?
now we're finding that they get scarring,
Wow.
which is the scary part. Their
That is
ED
so
is the
scary.
irreversible version. It's not the psychologic one. It's the irreversible. So from the 5-alpha reductase community, the apoptosis, the cell death that leads to the scarring, is due to inability to synthesize DHT, dihydrotestosterone, which is the goal of the drug. So you don't have acne in one end, or you don't lose hair on the other end. But you don't have penile smooth muscle in 1 to 3% of patients who are susceptible.
Wild.
So that's horrible. And then the PSSD community, we've identified oxygen radicals. So O2 is the normal oxygen. If you make it O3 negative, it's really an aggressive chemical or molecule, and it goes after smooth muscle, causing apoptosis. So it's the same concept as 5-alpha reductase hurting tissue, as SSRIs hurting tissue. So yeah, SSRIs are supposed to act on the brain. Guess what? They also act on penis.
Gosh. So
We're stuck in
I know.
craziness, right?
Well, let's take it back a little bit. You were actually the senior author on the Viagra paper.
Yes, it was May 14th, 1998. I can tell you exactly that.
That's
date.
amazing, first of all. Such a huge accomplishment. But that changed the game for men's sexual health.
Yeah, I mean, it was the first ever oral product. It wasn't designed for patients.
Yes.
This was to get the word out to practitioners.
Yeah.
No, we haven't ever published the phase 2 and phase 3 data from the multi-institutional phase 2 and phase 3 trials that the FDA required. So that was the first time it was published.
So what was?
By the way, there's a whole story to this thing.
I want to hear the
So
story.
I was first author, and the New England Journal's in Boston, right? So I'm
Yeah.
in Boston. I
Right.
was in Boston
You were in
at
Boston,
that
yeah.
time. Now in San Diego, happy.
Especially
but-
right now where it's snowing and like
Yeah,
negative.
it could not
3
be
degrees,
any
yeah.
more pleasant to be here. So we submitted it, and we said, hey, a no-brainer. Everyone would realize how important this was. It got rejected
Really?
by the New England Journal. They wanted this, so we changed this, and then we resubmitted. 7 rejections, 7 consecutive. It took us, I don't know, but 7-8 months to get it through the New England Journal editorial board. I have to tell you, they are not easy.
I'm sure not.
But
yeah.
what happened with the New England Journal is really fascinating because what they required at the end of the day was our data was based on the IIEF. We talked earlier on the FSFI, Female Sexual Function Index, but the International Index of Erectile Function was developed by Pfizer to get it through the FDA, which required a questionnaire.
Yeah.
Had to be validated. That takes another few years to do,
Right.
a few dollars. But it was a validated questionnaire, the IIF, and we passed all the standards of placebo this way, sildenafil that way, statistically significant difference. And the New England Journal said, there isn't a doctor on earth that can know what the F you're talking about with an improved IIF. If you want to get this through, you're going to have to go back to each and every patient's diary, find out, because we had their erection hardness data.
Yeah.
You know, I took the pill, and my erection was almost hard. That would be 3.
Yeah.
Or my erection was really soft and couldn't be used. That was the 1. Or my erection was this boner thing, and that was erection 4. But we had all that data, but we never used that data. It was just, how that they collected that. So we had to go back to the thousands of people, all their uses of the medication, and get their diaries to identify when they had a 2, to be in the trial, you had to VD. So it was, a lot of people were onesies and twosies.
Yeah.
But then on the drug or placebo, they could be a 3 or a 4.
Yeah.
So we took people who had a 3 and a 4 as the people who were able to have sex, and how often that happened on active drug, and with that we got approval. But boy, oh boy, that was an issue. But actually, it made it more real. I think the New England Journal is the New England Journal because it is the New England Journal. Yeah.
Yeah.
So do you know what? I'll never forget this. What was the percentage of active drug users, sildenafil, to get them from a 1 and 2 to a 3 and a 4?
60%?
69. It was a great number. Of course, 69%. And I said, this was made to happen.
It was so true.
And it was only like 23% for placebo, something like that.
What was the response by the medical community and then patients?
Yeah, so I was the first author, so I was the communication person.
Yeah.
We didn't have cell phones and stuff then. It was phones.
Yeah.
So our office was insane. It was, I mean, my poor staff hated me. But we fielded every call, and but they were from women. That was the crazy part.
Yeah.
I assumed everything would be men. But the women were saying, okay, Viagra's for them. I don't have orgasm. I have pain when I have orgasm. I have arousal problems. I can't, I have no interest in this. Boy, it really hurts when he penetrates me. I mean, all the gamut of female sexual dysfunction things were brought up. And my response was, hey, I'm a urologist. I deal with men. Go to your gynecologist. Someone will help you.
Yeah.
And inevitably, most phone calls came back and were saying, gynecologist says, go see you. I don't deal with this stuff.
It's so interesting to me because I also mistakenly thought for a long time that gynecologists dealt with all the menopause issues. And and there is...
I thought you were going to say sexual health issues.
That too, but you already addressed
they
that.
do not.
But so that was what put the onus on me to really start learning all this stuff because I was like, well, who's going to take care of
AUA
these
has
patients?
guidelines now.
Now they do, but I mean, even when I trained, there was not, there wasn't anything. So
we just lectured in the government Kimbrough thing.
Yeah,
I gave the whole menopause thing.
That's great
because the AUA has guidelines now.
Yes, well, just for the genital
Guess
urinary
what?
syndrome.
Gynecology does not have guidelines.
Yes, yeah.
Isn't that weird?
That's crazy.
That's pretty weird. Anyways, the phone calls from the Viagra led to the realization that we had to deal with women, that the parallel track, urology is a tract in sexual medicine. At this presentation, there's a sexual medicine group of abstracts presented and talks given. They have stones, they have cancers, but there's a track called sexual medicine. And that comes from 1970s when we started doing penile implants. It became a part of urology.
Yeah.
There's no part of gynecology in sexual medicine. It's so weird.
Yeah.
So it's just like a big hole in teaching and understanding and education in gynecology.
Well, I've always believed that the people who do fellowship in female pelvic medicine, like urogynecology,
they don't get this.
They should, though, right?
Well, should and get.
I mean, we're literally operating in the vagina, and
Yes. But you know, it's like radical prostate patients. They don't necessarily want to know what evil they're doing. There's a lot of evil when you put a sling across the urethra. It's as if the urethra doesn't matter. But let me not go there right now. We'll do that lecture another day.
That's another day.
Okay, so from the point of view of Viagra, it led to ISWISH, because where I'm going is we realized there was no knowledge in this area. And we put together a course. Over 1,000 people showed up, and then we started ISWISH. So ISWISH was started in basically 1998, so it's 28 years now. Crazy.
That is crazy. Let's talk a little bit about erectile dysfunction in men. Nowadays, we're seeing a lot more young men with issues with erections. Why do you think that is?
Shocking. Finasteride, PSSD. Yeah, we're seeing that. Another crazy problem for young people is the dysmorphia of of wanting to have a testosterone value of 4 digits.
Right.
like they love looking at themselves in the mirror. They love competing. They do anabolic steroids. And as soon as they get off of them, their testicles shrivel beyond belief. They get scarring of their tissue. They get a severe hypogonadism. They're like PFS patients. They don't have testosterone support of their smooth muscle, so their smooth muscle dies. Yeah, it's and then there's this other weird thing about young people in fraternities, especially. There's a thing called jelqing, JELQING. It is the most bizarre thing on earth. You have exercises to lengthen your penis, to stretch your penis, to grow your penis, because at some level, you're only going to date people because you have this very long penis. That if you have a short penis, you don't get that. So it's really weird. But they do a lot of damage to their penis. Introduce another sexual dysfunction called hard flaccid syndrome.
Yes.
That's one of my favorite topics. I love hard flaccid, not that I love it in the sense I love working with these patients because no one understands them, no one deals with them. It's sort of this new entity, but it's ostensibly the first sexual dysfunction that's not in the erect state. This is a flaccid state problem. Their penises are shriveled, cold. There's this unpleasant discomfort because of the shriveled state. They can't pee. They can't have a bowel movement. Their scrotum is riding high. They're like miserable with this stuff. And it's called hyperactivity of the hypogastric nerve. That's what HFS is. That's why I'm fascinated with it. It's another neurologic thing. They can't pee because the bladder neck is closed. They can't have a bowel movement because the hypogastric nerve is activated. Their penis is shriveled because the smooth muscle is under amazing contraction from the hypogastric nerve. And then it's basically a game, a detective's game, to find out why, which region is this coming from. Actually, the greatest discovery that has happened in sexual medicine is region-based medicine. We developed that with the PGAD in 2021, but it applies to everything. You know, where is the trigger for all of this happening? The jelqing injury, that would be region 1, the end organ. We see hard flaccid in people who have bicycle riding, like they do the marathons, the triathlons, the whatever you're doing with biking, the 600 miles a month biking, crazy stuff, and they have numbness as they're riding their bike. They get pudendal neuropathy. And then the people with back injuries, that's region 3, the cauda equina. Region 4 is the spine, region 5 is the brain. But region-based medicine, to find the trigger is really cool. And with this other group, SRPEs, these are sleep-related painful erections. These people have sleep deprivation. Their penis is rigid when they sleep. They have to get out of bed, walk around, pee, then erection goes down. 2 hours later, it's back up and causing them pain and waking them up. So region-based medicine will tell us where the SRPE is coming from. PGAD at GPD, the genitopelvic dysesthesia, the weird feelings coming from the genitopelvic area, that's region-based. So it's opened up the trick to understanding all these unusual sexual dysfunctions.
Well, until recently, we didn't even have treatments for some of these region-based issues.
But now we do, which is because the amazing contribution of sexual medicine to medicine is region-based medicine.
How do you think, in terms of hard flaccid, since you mentioned it, do you think there's a pelvic floor dysfunction contribution?
Region 2. That would be region 2.
Yeah. Because that's what I see a lot is where these, they're very tense in their pelvic floors and they're causing this basically involution of their penis almost because it's so tight.
Guess what we've done? We've identified an objective test for HFS. This is why I love this condition. It's so fun. So we have this thing called forward-looking infrared. I don't know if you've ever heard of it. It's FLIR. The way I explain it to patients is in Boston, there was someone who, near the finish line of the marathon, threw a bunch of bombs and really made horrific, deaths and dismembering. And then they escaped into the Boston neighborhood, and a helicopter had a thermal camera and found a guy lying in a boat. I don't know if you remember the story, but he was lying in a boat that was because it wasn't ready for the season to put the boats in the water. He was in the guy's backyard, but he had found his way into the inside of the boat. But they found him there, and they captured him through sort of the thermal imaging. So we do thermal imaging of men's penises. And the glands in hard flaccid states, about 80 degrees. It's supposed to be 98.6 degrees, by the way. Yeah. And then when we treat them, their penis becomes 98.6.
Wow.
So we now have an objective test for it. It's kind of cool. And we have a metric for seeing the effect of a therapy.
I heard that when you were learning about this, you actually used some cold gel.
Yeah, on myself.
Yeah, on yourself.
So I don't know if you've ever done this. You can put on your clitoris, I guess. It's really awful. I mean, I put this very cold. I put the ultrasound gel in the freezer, and it was really cold. And I put it on my penis, and I started seeing patients. It was really hard to concentrate. It's really it's an impactful condition. I think that was one of the good reasons why I studied it, because it's truly a problem, and it's completely ignored. I mean, doctors think
they just think they're crazy.
They just think they're crazy.
Yeah. So what have you found to be, obviously pelvic floor physical therapy we've sort of touched on, but
so
what
that'd be
other
region
things?
2. So region 1, when it's typically a jelking thing. So it's a dorsal nerve neuropathy, basically, is what it ends up being. And so we do what's called prolotherapy, 5% dextrose into the area of the nerve injury. We do shockwave therapy to that area. We do alpha blockers. We do PT stuff. Anyways, we have reasonable
I'm basically asking
treatment
you to be
outcomes.
my textbook, so you know.
We take care of them. I'm trying to think there's a fourth thing that we do a lot of, but we're developing. Yeah, this is another cool thing. We're working with a pharmaceutical guy. He's developing an L-arginine based warming gel. So if you can get rid of the cold, you can get rid of the feedback cycle it's cold, which is uncomfortable, which is causing more hyperactivity of the hypogastric nerve, the sympathetic activation, which perpetuates this whole thing. So if you break the cycle by putting a warming gel, which is just a vasodilator L-arginine, like completely safe, it warms the penis. So you can see the temperature go up on the FLIR camera, and they have the penis now doesn't shrivel anymore. Kind of cool.
Very fascinating.
We'll figure all this out, I promise.
Yeah.
Give me some time.
Do you think porn is playing a role in this new erectile dysfunction we're seeing in young guys?
Oh boy, that's a great controversial topic. There's people who view porn as positive. It's allowing them to learn because there's limited education. And there's people who view it as completely the opposite, as evil and addictive and all that stuff. I'm going to stay out of this conversation because it's not biologic focused. We use porn so patients can get erections in the office. So from my point of view, it's this fabulous thing. But I'm not qualified to talk about
You think the answer's
addiction
somewhere in
stuff.
between?
Well, I mean, it's like everything else. You have access to the internet, and if you use it appropriately, look, you do social media. There's some perfect social media, like Rena's work, and there's some less perfect that discusses the role of spinning around facing east, and you get cured that way. Okay.
Yeah. Venous leak. That's a huge problem that we're seeing. And I think we're learning more and more that a lot of erectile dysfunction is actually venous leak
totally.
more so than arterial dysfunction.
Totally.
I mean, you've mentioned some causes of venous leak, obviously, but I think people are just perplexed. Like, how do we, because it's very difficult to treat it with traditional means, right? They don't respond as well to medications or injections as people who have really, truly arteriogenic dysfunction. So what do we do about it?
So venous leakage is the equivalent of you're a firefighter, you're in the city of Los Angeles, it's the summer, and all you do is breathing smoke. You have pulmonary fibrosis. It's excess collagen in your lungs. Okay. Or you're a drinker and you have liver cirrhosis and you have excess collagen in your liver. Or you have a heart attack. You stop blood flow to the muscle turns into scar tissue. And when your heart pumps, instead of the ventricle squeezing, getting all the blood out, the ventricle squeezes only a little bit. That's heart failure. So you have lung failure, you have liver failure, you have heart failure. Let's say you drink a lot of mercury, and now your kidney turns into mush, and it's full of scar tissue. Basically, venous leakage or accumulation of connective tissue within the erectile tissue is the failure of like every other organ. We're just like a part of all organs. They fail by getting connective tissue. The physiologic impact is that the tissue can't expand. It is a requirement to expand. The penis, unlike the liver, spleen, kidney, changes volume and physiology. Does your liver change in a 24-hour day?
I hope not.
Yeah. Do your fingers, do your arms, do your muscles? I mean, nothing changes. It changes for a reason. It's not because it's fun that it gets wider and longer. It gets wider and longer because that's how it blocks the tissue. Its expansion against the capsule stops the space that where the veins live, which is just the space between the tissue and the capsule. So it's called the subtunical space. The subtunical venules it's a sponge. Blood is getting into the sponge. The only way it can drain is the peripheral spaces because each space just communicates to another space. The only way out is the peripheral spaces. But if the peripheral spaces are squished by the expansion, then you trap. I mean, essentially, the penis is the only organ that has a closed compartment during its physiology. Every organ is blood in, blood out. If you have blood in, blood out with the penis, you're kind of screwed.
Yeah.
So they're essentially, all of ED is that. And it's a degree of how much scar. And now with ultrasound, I can tell you how much scar you have in your penis. And basically, you have two choices. You have a choice called symptomatic treatment. You magnify whatever muscle you have, its ability to maximize relaxation. So 4 treatments for that. You have your pills. You can stick needles in your penis and inject vasodilators. You have subcutaneous bremelanotide. I think we've talked about that with the orgasm. And we have intracavernosal Botox. All those things maximize muscle relaxation. Then we have another strategy called disease modification, where we can grow muscle. If we can grow muscle, we can change the ratio between the muscle and the connective tissue. You want as much muscle as you can to lessen the effect of the too much connective tissue. So for that, we have Shockwave and PRP. More or less, you have 6 treatments for ED before you get to the implant.
Yeah.
And you play with those strategies.
Are there supplements that you recommend for erections?
I mean, truthfully, if you want to do evidence-based medicine, you got to do placebo-controlled double-blind things, and there's no data on supplements.
Right.
It's kind of like snake oil a bit. I'm sure there are some supplements that are good. Supplements can be bad. There are supplements that are basically 5-alpha reductase inhibitors, and there's supplements who are used for depression. And we've already talked about
Right.
some of those not being so perfect.
Yeah. And the supplements have a wider range of activities that you can't necessarily quantify as well as you can with pharmacologic agents. And they're adulterated sometimes.
You know, what's fascinating about supplements, I love this. I'm glad you brought this up. So there are people who took finasteride and they're screwed. There are people who took SSRIs. They're equally screwed. And their conclusion is drugs are bad. But they'll do 1 million supplements as if magically supplements are not harmful, which is completely false.
Completely false.
Supplements.
And we've seen liver injury. We've seen just so many horrible things. And, you know, I actually read a paper that people who have too much copper, it actually causes erectile dysfunction. And some of these supplements have a lot of copper in them, you know?
Well,
so,
I mean, even I'm learning. I didn't know this.
Yeah, I read this paper and I was like, oh, that's so interesting. You know, so people think, oh, it's just a mineral, right? It's not a big deal. But yeah. You mentioned Shockwave and PRP. So let's talk a little bit about
We do
those.
a lot of that.
Yeah. So
we
tell
have
us
2
about
machines.
Yeah.
I'm part of the International Society for the Study of Medical Shockwave Therapy. I love this.
I didn't even know there was a society.
Oh, God, it's huge. And so it was in Amsterdam last year. Of course, getting to Amsterdam, it's just fun.
Yeah.
So there's a reason to join the ISMST. But so I meet a cardiologist, actually a cardiac surgeon. Okay. And basically, it's a life-changing meeting. You know, sometimes you go to a lecture and you sit there and it's boring. And sometimes you go to a lecture and say, holy God, I'm listening to something that's unbelievable.
Yeah.
So here's this cardiac surgeon who shows movie of him opening the chest, having the beating heart. This is on all his video. And he takes a shockwave device and he shocks the beating heart.
Okay.
So his paper, which is published, takes people with heart failure. Their muscles are kind of dead. They have too much scar tissue. We've had this conversation. And guess what shockwave therapy does?
It
fixes their thing. They generate more muscle. Their contractions increase. They get out of heart failure. They're able to run and do all the things that otherwise they could never do. And what was the treatment? Shockwave therapy.
Wow.
So it's the first human example of the capability of the regenerative nature of muscle growth in vascular tissue. I think it was, I walked out of that lecture. I went straight, be right to the guy, shook his hand, took a photo with him, and I said, I want to know everything you're doing because we're going to do the same thing in the penis. So that's what we ended up doing. Double-blind, placebo-controlled trial with Shockwave. It was fun to do the placebo, by the way.
Yeah.
You know, like Shockwave you could feel. So we had to figure out a way to do Shockwave where we're not doing Shockwave.
Yeah. So how'd you figure it out?
So we put people in a curtain so they couldn't see what they were doing. We had noise-reducing headphones so they couldn't hear. We put the probe on their penis, activated a recorder of the sound of the shockwave, and we're putting it on and moving it up and down as if something's happening, and the sound makes it sound like something's happening.
Yeah.
But nothing happened.
Okay.
Which was very cool when we analyzed the data, because we do before and after ultrasound to see if the ultrasound reduced the black and increased the gray. We have already talked about gray is good. So we couldn't change the ultrasound by doing no treatment to the patient.
Of course.
Well, of course, yes, but who knew, right?
Yeah.
You had to test that.
Yeah.
And the only way we could increase the gray was to do shockwave.
I think we've had over a decade of data on shockwave. What frustrates me is that we're still not. It's still not shown to be. It's still not in the guidelines for erectile dysfunction.
They made new guidelines, which are even worse now. They're saying don't do it.
Yeah.
So I think the attitude of regenerative therapy is sort of incorrect. They're trying to make it a therapy like Viagra. You know, that this independently can improve erections and sort of cure you. I think shockwave therapy and PRP therapy are therapies that help your current state of too much collagen to lessen the collagen and make injections which didn't work now work, to make Viagra which didn't work now work. If you view it that way,
same thing with the Botox.
It's the concept of avoiding a penile implant. Now there are people who say, I just want my implant, just do it. This is torture, all these crazy things. It's also expensive because none of these are really covered. But there are people who say, I'm not doing the implant. I had my radical prostatectomy. I'm done with surgery down there. You make me have erections and figure out how to do it. I think these are valid ways to help people.
Yeah. I definitely am convinced by the Shockwave. PRP, has been some controversy. There's been some randomized controlled trials that were negative. So what do you think about that? Do you think it works alone?
Well, we do
or?
before and after ultrasound with
Yeah.
PRP, we do before and after ultrasound with Shockwave. In our population, I could show you benefit.
Okay.
I think it's the same thing. More or less, they activate mesenchymal stem cells, which then make downstream muscle cells. And that's essentially what you want.
Yeah.
But do you make it in a degree to which you now can walk around and be a 12-year-old boy? No, not going to happen.
Do you think if there's guys listening who are like, I want to have the best erection possible, is there value in someone who's normal using these therapies?
That's a fabulous question. If you're normal, you shouldn't be doing anything that has risk, and obviously anything that you do has some risk. If you ask the question, if you are on Viagra and you already have a problem, should you now consider to do prophylactic improvement of your smooth muscle health? I think you have an argument there.
Yeah.
Because you're already on a therapy and you're already down that slippery slope of evil. Because I'm on ISMST, this medical shockwave therapy, my brain is saying to me that the current strategy where the equipment is bizarrely expensive, you have to go to a doctor's office, you got to get multiple treatments, and then you go home. That's not the correct way to do shockwave. I believe shockwave therapy is something that you do like insulin. You just keep doing it.
Yeah.
You keep activating stem cells more than stem cells are being activated inevitably, because all stem cells are being activated. I think it's a thing you do at home, like you exercise, like you eat well, like you shockwave regularly. It needs to be a home device.
Well, there are home devices, but they're not the same.
No, they're not shockwave.
Yeah.
That's bullshit.
But
Excuse me. Didn't mean that word.
I just want to be clear, because people might hear this and say, oh, I should just go buy that shockwave therapy.
It's called Phoenix, and it's a complete waste of time. Yeah. It's radio ballistic pressure waves. They do nothing. They have
it's like
no
an expensive
energy.
massage.
Double-blind, placebo-controlled radio ballistic pressure waves don't do anything.
Right.
Yeah, it's like a massage.
Yeah.
You massage your penis many ways, like jelking. But true, genuine shockwave, for reasons unclear, is they make bells and whistles, they make it expensive. It really needs to be a home thing.
Yeah.
It needs to be declared by the FDA, not a device class 2, which means you have to have a physician involved, but class 1, which is what radio ballistic pressure waves are.
Yeah.
Need to make them the same.
So as of right now, if anyone is giving you a device at home, it is not a shockwave.
It's not a shockwave.
Formal shockwave
It's
device.
a kind of a waste of your time.
But I think the other challenge is there's a lot of, so there's cheaper shockwave machines that are radial versus focus, and people.
Well, they're not shockwave. Don't make that mistake.
But that's what they're calling them.
Yeah, but it's not shockwave. They're lying.
Right. So, but for the average consumer, it's very difficult.
They're called acoustic waves.
And they look the same. They sound the same.
By the way, a radio is an acoustic wave. It's cheaper to take a radio next to your penis, by the way. It's the same. Sure. You're saving a lot of money.
Right. So just make sure you ask that you are getting focused shockwave, because I think what happens is these people get taken for a loop. They get, I'm getting shockwave. It's cheaper than
if it's
whatever.
in your shopping mall, it's probably not.
If there's
real.
No doctor involved.
Yes.
Be thoughtful.
In our office at San Diego Sexual Medicine, only providers provide shockwave. We don't have techs doing it.
Yeah. I do it myself too.
Yeah. I think it's a lot of fun, actually, but another conversation.
Well, it's like a good chat with your patient and hang out, So you already told us about how you switched over to female sexual dysfunction.
Well, we broadened the version of sexual medicine for men to sexual medicine for both genders. I think that's the way to think of it.
What do you think is the most misunderstood thing about female sexual function?
That there's no help you can get, because there is plenty of help you can get. You just have to find it. I think the nightmare is the provider availability is pretty limited. ISWISH. If you're a woman, find an ISWISH provider. You have the best chance.
Absolutely.
But there's so much we can do for HSDD, for arousal, for orgasm now, for specifically the pain disorders.
Do you think we over-psychologize sexual dysfunction?
I hate to get involved in that, because psychology is just so important, and it's intimately involved with everything.
Yeah.
It's all sexual dysfunctions are 100% psychological.
Absolutely.
But a lot of them are biologic. And the biologic is the trigger that sort of manifests the psychology.
Right. Once you have a problem, you can't stop thinking about it.
Yeah,
Yeah.
and it just festers.
What I mean is, I think that a lot of people go see their doctor and they're told it's all in your head.
Yeah, well, that's the nightmare.
That's the problem.
It would be wiser for doctors to say, geez, I'm not trained in this.
I don't know.
I don't know.
Yeah.
And then rather than give people the it's in your head thing.
Yeah. I'm sure you say, I don't know. And I say, I don't know all the time to patients
I
because there's
do.
things that we don't know.
But then I go on AI.
But it's not perfect.
It's not perfect.
It's not perfect. You know, open evidence is a great tool that we have. I don't know if you've used it.
I don't.
It incorporates all the research from like journal JAMA and New England. Like it gives you very detailed.
I don't think they're really good open evidence in sexual medicine.
They're not great, but meaning you can ask the same question on different computers and get different answers. Yeah. So it's not always perfect. Yeah. You've talked a lot about oral contraceptives,
right?
And how they impact female sexual function. Now, I think they're great in giving women the ability to decide when they want to get pregnant, but there are some women who have real sexual dysfunction after using them. Can you talk about that a little bit?
Hormonally based contraceptions goes back to the 1960s, where you were able to stop ovulation. So if you could stop ovulation with medication, you can't get pregnant.
Right.
Okay. But magically, for reasons unclear, 100% of hormonal-based contraceptives raise a protein from the liver called sex hormone binding globulin. Mm-hmm. And I don't mean raising it from 25 to 28. The normal value is in nanomoles per liter, 25. It goes to 400 or 500, okay? So sex hormone binding globulin is a globulin, a protein with lots of amino acids that binds, sex hormone binding, to sex hormones. It binds sex hormones. Of the things it binds is testosterone, rendering it not available. Mm-hmm. So whatever you have in your body, it's all sort of stuck on this protein and not really available. Mm-hmm. Okay, that's 100% of users. There's 50 million users. So 100% of 50 million people have low testosterone. Okay, but not everybody has sexual dysfunction. God bless those who don't have sexual dysfunction. Their androgen receptors are very happy dealing with low testosterone. They'll still make the protein needed based on their testosterone. But there are a bunch of people who have really lousy androgen receptors. I studied this. We measured the androgen receptors in people on this product called Yaz who did and did not have symptoms. And what discriminated from them having and not having was the quality of their androgen receptor. So people with crappy androgen receptors require higher testosterone to make the protein, but they're not getting it at 50 million people. So yeah, it's kind of a nightmare. So there's a thing called LARC. I don't know if you promote LARCs or discuss LARC, long-acting reversible contraception. There have no side effects sexually. So if you had to pick and choose between a hormonal birth control, which can 100% lower your testosterone, not can, but does.
And that manifests in low sexual desire.
What low sexual desire, depression. How many young kids are in college with depression? Guess what they go on while they're on hormonal contraception? They go on SSRIs. That's double nightmare. Yeah. Double jeopardy for these people. Yeah. So it's a drug causing another drug problem. Yeah. Welcome to America, to women and their sexual problems.
Well, let's talk about low sexual desire.
Okay.
What is your, I think we've heard it too much. Go drink a glass of wine and relax, which is all bullshit. What do you do for women with low sexual desire?
Well, we listen to their story, ask them lots of questions. They're not wanting to want. So whatever their reason is, at the end of the day, it's like orgasm. It's a central thing. There's an imbalance in excitation and inhibition. Mm-hmm. And remember, we talked about orgasm where they both work together? Yeah. These ones work opposite. Yeah. So if you want to be interested, you got to access your excitation chemicals and you got to turn off inhibition. Mm-hmm. So there's two, amazingly enough, FDA-approved products that activate excitation or turn off inhibition. So one of them, the first one was flabanserin, which, by the way, at this year's This Wish, you're going to watch a movie called The Pink Pill. I don't know if you've actually probably already seen it.
Yeah. No, okay.
You'll see it
well
again.
I'll see it again.
It's really cool.
Yeah.
So flabanserin is an agent that's FDA approved for that. It's a daily pill. So a lot of people like the concept of not dealing with it at the time of sex. Just take it all the time. And then there's the subcutaneous bremelanotide, FDA approved for HSDD. But a lot of people like the idea of taking it only when they have sex. It's kind of like a Viagra concept.
Yep.
For men, it's not a stretch to say I want a better performance. Let me take my Viagra. So women will say, let me take my Vyleesi. In a discreet way, they'll do the EpiPen injection and have many hours of lots of dopamine.
Yeah.
So they'll have excitation more than their current inhibition. So you have to discuss if it's situational or if it's lifelong or if it's you have to get into the meat of all of this.
Yeah.
But we do have two products, and then of course testosterone is it's an agent that clearly is involved in desire, and there's a lot of people on birth control pills who have done away with their testosterone by raising this binding protein. So there's lots of stuff to do.
And that raise in that binding protein doesn't go away, right? After?
So, yes, now we're getting into another drug and its nightmares is it doesn't ever return it to its
baseline.
value prior.
Yeah.
Yeah, the body learns to stay with high SHBG. So as that person ages, the price for taking birth control pills at a young age is a permanent elevation of SHBG, or a permanent, if you like, low testosterone state. So that leads to depressions and low interest and bone disease and muscle disease and tiredness and blah, blah, blah. It's horrible.
That is horrible.
And add to the sad state that there's no FDA-approved treatment for testosterone. No one's even measuring testosterone because they have nothing to treat with, unless you don't mind going off-label and using Bale testosterone products.
Yeah. Which work.
Yeah, which work and are widely used in our office.
Yeah. Same. How do you feel now? I think we're having at least more discussions about testosterone in women. More people are prescribed on it. Do you worry about, I think what I've heard from people where they accidentally will take more than needed and they feel great. Do you worry about people being on super physiologic doses of testosterone?
Do you ever ask that question about men?
I do. Yeah.
Okay, good.
Absolutely.
You're not picking on women.
No, of course.
It's a risk benefit. It's side effects. What is super physiological? We haven't even established what is the physiologic levels of women.
That's very true.
Certain women need more, and it's because of their SHBG so blessedly high, and some need less, and some have bad receptors and need more. So I don't know. We go by side effects and benefits, and we ask them, are you happy being where you are? Some people will say, my best friend is the person who takes hair off my face. So because I love the testosterone, I pay the price of having a little bit of a mustache, but my whatever you call these people, ologists for hair, estheticians,
yes,
or the laser things that they do for their mustache. It's what's important.
Yeah. Do we actually know what normal is in women? I know we always sort of generalize and say like 10% of men's dose. Or
so I did a study.
Yeah, because I know there's like a few studies.
Yeah, with Andy Gay, who is not with us at this moment in life, but a brilliant guy. We took nurses and we gave them the FSFI. And if they scored greater than 26, that's the level consistent without sexual dysfunction. So to engage in this trial where we drew their bloods, you had to have an FSFI greater than 26.
So you had to be normal, essentially.
Without sexual dysfunction. The word normal, weird.
Considered, yes, without a dysfunction.
Without a dysfunction. So we then drew their blood test. 0.8 nanograms per deciliter was the calculated free T of this population.
Okay.
And it's what I'm calling the blood test result consistent without a sexual dysfunction.
And what was the total testosterone? Do you remember?
Well, everybody's SHBG is all over the map, so we focused on free testosterone.
Got it.
A little more practical.
Yeah.
It's really frustrating to have someone who has a total testosterone. Classically, it's 40 nanograms per deciliter, but let's say it's 65. But so they say, oh, you have ovarian, polycystic ovary thing with high LH or something. But it's not true. For some people whose testosterone is 65, they're good. And for some people whose SHBG is still 400 from their birth control pill use, 65 is not even
Enough.
anywhere near
Yeah.
enough.
Yeah.
Yeah, so it's confusing.
Over your lifetime, received innumerable awards, right? For all your amazing
But
work.
my highest award is speaking on your show, by the way.
But what I wanted to know is, more than that, what have you been most proud of in your career?
Oh my gosh. Most proud of in my career was working with my wife, I guess. That has been my biggest honor. I mean, we met at age 19 and we're still together.
That's so
We have
sweet.
sex all the time still. May I announce? Yeah, everything I do is because we work together and talk about it. And we have this bizarre life where our work is our life and our life is our work. So it's been really fun.
That's awesome.
Yeah.
That's so
It's
great.
been a good thing.
Yeah. Yeah. What's something that you believed early in your career that you now know is completely false?
So so we published in 1991 that the chemical released by the nerve that caused penile erection was nitric oxide. We were the very first lab, JCI, Journal of Clinical Investigation, 1991. That was the first ever NO sort of identification of what led to penile erection. And that led us to Pfizer, who was developing, it was a phosphodiesterase type 5 inhibitor, but it required NO to make all things work.
Yeah.
And they were studying it for angina. So we were contacted by Pfizer and worked very carefully with them to switch their development from angina to ED. So we had lots of meetings. So I would go to the meetings saying, whatever you're doing, God bless you, it's impossible to develop an oral pill. Okay?
Yeah.
And I got up and I'll still tell you, this is what I said. There's 5 liters per minute going through your body. That's your cardiac output. 30 or 40% goes to your liver. 20% goes to your whatever, some other major organ. Now, the penis gets maybe 5 mLs of that. That's 0.1% of the cardiac output. Okay, you're going to take a pill. It's going into your mouth. And 0.1% gets to your penis? Give me a break.
Right.
How is that going to get enough drug to make this? It was an impossibility. Plus, at that era in the 1990s, the only way we were getting erections was by injection. So you had to have sufficient smooth muscle relaxation by the injection. How could you get something systemically that wouldn't cause you hypotension that was causing smooth muscle relaxation? So I publicly said, multiple meetings, I'm so happy to work with you on this project. It will never happen. I just need you to know it's 100% waste of everybody's time. And of course, history shows me to be extremely wrong.
But wasn't during the angina trials that they saw these guys were having spontaneous erections
Correct.
and not returning the medication
Correct.
at the end of the trial because they were happy about it?
But that was, right. They got the signal, but we were developing, so we didn't know if they were ED or they were normal and they're just getting better erections or something. But to take a population of men with ED, radical prostate patients or, just vascular paths, hypertension, high cholesterol, diabetes, obesity, the community that we all see and love, giving them a drug to help their ED that isn't going to affect everything else seemed beyond reality. And I couldn't have been more wrong.
Well, it does affect there's some data that it may improve muscle blood flow, cardiac blood flow, right?
Only positives. Prevent heart attacks,
I already know the answer, but do you have any concerns about people being on these medications long term?
Oh, God, no.
Yeah.
I think, to be quite honest, I think every male should be on this all his life.
Yeah.
I'll go on record as saying that.
I think tadalafil is a wonderful medication.
Yeah, I think you don't have to think about it. You get nocturnal erections from just taking a pill. It lasts 36 hours. So it's one of those things that it's like vitamin tadalafil. Or
like
vitamin
that.
C, Cialis, I guess it's a better way to say it, right?
The other thing, some people are still worried about taking these medications because they worry about their heart.
Well, God bless them.
No, but is there any indication where you would say, no, I can't give you this medication?
Well, sure, nitrates use.
Of course, yeah.
That's the biggest thing.
What about if their heart
But
health is
nobody
not?
takes nitrates anymore, so
It's rare. It's rare.
Yeah.
There are still some people who take them. But what about cardiovascular disease? Is there I know there's a consensus statement, but what is the point where you'd say, hey, we gotta sort of talk
they're
to your
going to
doctor?
be the rare condition, but in general, incredibly safe, incredibly helpful, and in my opinion, should be very widely used.
I think that what I say is if you can have sex, if you're like physically able to have sex, you should be able to take the medications. If you can't get through a
Oh,
sexual
yeah, well, that's a
encounter,
good point.
if you can't get through a sexual encounter because you're so,
can't-
physically exhausted or
Right.
then probably not the
That's
right
that's a
medication
good
for you.
message. I should steal that from you.
You're welcome to it. I'm sure I've stolen stuff from you. So. Okay, if you could put up a billboard tomorrow about sexual medicine for everyone to see, what would it say?
Don't beat your head against the wall because you have a sexual dysfunction. Get help because we're really good at this. The nightmare is there's not enough sexual medicine providers.
Mm-hmm.
But if you could actually find a sexual medicine provider, we're pretty good at helping people. So I think the billboard would be, to seek help.
Yeah.
Go for it.
Yeah. Where can people find your work, find you if they want to see you? Where can they learn more about you?
Go to you. Rena sends patients here. San
do.
Diego Sexual Medicine.
I do.
619-265-8865. That's our
We'll
number.
put all the information in the description
God
too.
bless you.
We end our podcast with 4 questions we ask you. They don't have to be about sexual medicine. They obviously can be. But what is something you know now that you wish you knew earlier in life?
I'm in love with the region-based medicine stuff because it allows me, as I'm hearing a patient talk, trying to put where's this trigger coming from? And we didn't know that at the beginning. And it was very confusing and so confusing that we ignored it. We said, but I'm going to stick with the answer that what we know now, region-based medicine, is the model for figuring all these unusual cases out.
Yeah.
Like hard flaccid or SRPEs or PSSDs or PFFs, all these stupid acronyms. We're only good at that because of region-based thinking.
Yeah. What's a non-negotiable, something you have to do every day?
Take Viagra. Have sex frequently, orgasms regularly.
Yes.
Yeah, I think there is health to having sex.
Well, and your brain. Protect your brain.
Your brain.
You mentioned it earlier.
It gets you the blood flow.
Yeah. What's a life hack or health hack you'd share? It can't be have sex because you already said that.
I can't repeat have sex frequently. It's what I would say.
That's why I prefaced it because you already said. Okay, we'll let you have it. Have sex frequently. If you couldn't be a urologist or a researcher, a entrepreneur starting your own practice, what would you be?
A sex researcher.
I said researcher. You can't be a researcher.
I wouldn't be anything else. This has been a journey with wave after wave after wave of So we're fortunate in urology because the penile implant happened in 1973. I was a resident in that era.
Yeah.
My chairman did all the penile implants west or east of the Mississippi in Boston. We got everything. So as a resident, I was evaluating men with impotence. We didn't use the word ED then.
Yeah.
And I've essentially not done anything else in my life.
Yeah.
From day one. Sexual medicine. So, and then the Viagra turning to do both men and women has really cemented that concept. It's completely fascinating.
Oh, you know what? I forgot to ask you. Is Viagra? I'll edit it in.
You didn't have an orgasm recently, that's for sure.
Does Viagra work for women?
Does Viagra work for men? So we're finding that topically it does with a enhancement promoter to get it through the skin of the clitoris and vagina. Orally, I don't know. We studied it a lot. Arousal's not the prime issue for women. They walk into the office with, I'm not interested, it hurts, I can't have orgasm. They've rarely, it's not not impossible, but it's more of a rare thing that my arousal's off. Whereas a man, my inability to get aroused erection is kind of the premier thing. So it's boy-girl different.
I do think, though, that it's difficult for women to quantify arousal because they don't have a
I'm
visual.
sure that's true.
Right?
Yeah.
So they don't have a visual that they're
Right.
aroused. And so they may be conflating some of their low libido, maybe also due to low arousal.
I'm sure that's
right?
true.
So I wonder, I just don't think we have the right tools to really assess, because it's probably a combination of things.
I'm sure that's true, but it isn't what people complain of, and Viagra has failed every time. So,
Yeah.
but getting aroused is important to start the orgasmic arousal process.
Mm-hmm.
Not that arousal is not important; it's just not the complaint.
The other thing I wonder is for women, we know that erectile dysfunction is a canary in a coal mine for men, right? With cardiac disease. And it's probably the same for women. And I wish that message would get across more, because we might be saving lives, right? By talking to them about their sex lives. If we identify that they're at risk for heart disease, we might be changing the game for them.
Well, if this year's ISWISH, they're doing how to assess blood flow to the clitoris. They're doing ultrasound of the clitoris.
Mm-hmm. Yeah, I saw that.
Ideally, it picks up early vascular disease.
Yeah.
So your canary in the coal mine may still work, but you need an ultrasound machine.
And you need to get the clitoris erect. So are you going to be
Well, you have to arouse, yeah.
Yeah. So are you going to be doing intracavernosal?
No, I think the topical sildenafil may have a diagnostic role.
Okay.
Yeah.
Fascinating. All right. Great. Well, then will topical sildenafil work in men?
So I don't know the answer to that. It hasn't yet.
It's been tried, right? There's been some
definitely
combinations
been tried.
of things. Yeah.
Topicals have been tried. It's just that the oral
works so much better.
Yeah.
Yeah, there was that topical Eroxon, which there was a lot of hope for, but I think it fell flat a little bit.
It based itself on a placebo. It's not really the active drug.
Yeah.
Kind of weird.
It was weird. Yeah. All right. Well, thank you so much.
Rena, thank you. God bless you for having so many people. At the end of the day, we do the research, but we don't get the data. So we're in partners in this thing.
Absolutely.
And getting it out is very important.
Absolutely. And I feel honored to be able to sit down with you and get your time and your insights, because, you've worked your whole career in doing all this stuff, and it's so helpful to so many
people. The word work is probably not correct. I've enjoyed the journey. It's just been fun, really.
Yeah. That's great.
We don't work.
I think the people who do the most, affect the most change, love their work.
Yeah.
Right.
Well, as you do.
Yeah. I mean, it's true, right? You have to love it. Otherwise, you just won't keep going. So.
All right. Well, thank you.
Thanks. Thank you guys so much for joining me on today's episode of the Rena Malik MD podcast. Really quickly, if you like this podcast, just make sure you are subscribing or following the podcast. It is a huge difference maker for us, because it shows people that this podcast is really worth watching. It makes us higher on the podcast charts, and so more people can find us. And as always, we're going to take care of yourself, because you're worth it.